We're still in Unit 3, Basic Needs. We're now in Part 5, which deals with activity and mobility. It's an important need that sometimes gets neglected. Mobility impacts every area of physiological functioning and has psychological implications as well, particularly patients who are immobile for long periods of time. So I'm giving you your textbook resources. You do have your fundamentals text, Wilkinson, Treese, Barnett, and Smith. You can read the entire chapter if you choose to. There's a lot of good information. The first few pages are a review of anatomy and physiology. But really you can start focusing on pages 830 to 846. There's an awful lot of material about physical exercise in your textbook that we aren't really going to cover because there just isn't time to focus on that. You can also look in your clinical skills book to supplement your readings, because patient transfers, assisting with positioning, range of motion exercises, all those interventions that are really important will be found in that text. And it also provides a very easy to read breakdown. So those would be pages 350 to 420. Leaf through them and pick out what it is that you find important. Anyhow, so our lesson objective for this unit is to apply the nursing process to the care of a client with an unmet mobility need. And for the most part, we're talking about hospitalized clients who are either on bed rest or for whatever reason have impaired mobility. And so we'll discuss a lot of issues that come up with that. So we know that mobility and activity are important human needs because without them, bad things happen to the body. The body needs to move. And when we have immobility, it impacts every system in the body, including the skin, the cardiac, respiratory, intestinal, everything. And I'll show you that later. So in order for us to have normal movement and for us to have stability of that movement, we need a few things. We need an intact musculoskeletal system. Okay, so that's comprised of bones, joints, connective tissue, and skeletal muscles. I'm not going to go into an intense description of the anatomy and physiology of those things. Just know that a disorder that affects any of those things, for example, a fracture or a torn ligament or muscular dystrophy, is going to impact mobility more or less profoundly depending on the severity of the injury or disease. We need an intact nervous system. In order for us to have voluntary control of our movement, our cerebral cortex has to send a message that goes down to the spinal cord and into the nerves, makes the muscles contract. We also need some of our other functions. Cerebellum rules balance and gait. So for us to have stability of movement and coordinated muscle activity, we need to have a really fine-tuned system here. And so those are important. Now, some other structures that are important in other systems or needs that impact mobility are inner ear, people with vestibular disorders that have bad balance, more prone to falls because they have inner ear problems. And also we have problems with respiratory or cardiac issues. We'll have disorders of movement because we'll have activity intolerance. What happens if we can't supply the muscles with the oxygen and the nutrients they need? We're not going to get strong movement. We're going to get what's called activity intolerance. People feel weak, they feel puny, they feel wimpy. They can't walk a block. So they have activity intolerance. So that will impact their mobility as well. And then when we have disorders that involve nutrition, obviously muscles feed off glucose. They store it as glycogen for use later. If we have poor nutrition over a period of time, we don't have the right nutrients or the right micronutrients that will unlock those carbohydrates for us and help them perform their metabolic functions, we're going to have problems with our mobility. And usually that takes the form of activity intolerance. But we talked about the B vitamins and how they can sometimes cause nervous impairment, and that will impact our movement as well, because they'll impact the nerves that supply the muscles. So the way I see it, there are 4 basic components to normal body movement. The first one is body alignment. Your spine sort of has certain normal curvatures. Let me see if I can get a picture for you. Okay, and there you see the normal curvature of the spine. It sort of has a very mild shape. at the cervix or the cervical vertebrae. It sort of curves in, then the thoracic curves out to make better chest expansion. Then we have a little curve in at the lumbar vertebrae and then out again at the sacrum. And that's a very normal alignment. Now, people can have different types of posture that throw that body out of alignment. What I want you to take home from that, two things. When you're talking about your patients, when you're positioning them, you want to preserve that natural alignment. So when you're positioning them, you might have to use aids like pillows and things like that to keep that spine in alignment and to keep other parts of their body in their normal positions. Okay? The next concept that we're going to talk about is joint mobility, and it is important for joints to have mobility. Now, what I want to talk about with joint mobility, in order for the joint to maintain its health, it needs to move through a full range of its own motion. Now let's kind of take a time out here and talk about the different types of joint movement. Now here I've listed some of the different types of joint movement. It's not a list for you to memorize. I can already hear the questions. Mrs. Mulcahy, are we going to need to know this for the test? Well, eventually for 137 you are, because it's a way that we assess the musculoskeletal system. We look at the different movements of the joints and assess whether the joints are moving through full range of motion. I want you to become somewhat familiar with those terms, and you will find them in your book. Let me find them. Page 819. I'm just going to make a note, but we're not going to discuss them extensively right now. What we will do, and it's kind of a fun thing, we can play Simon Says in the classroom, and we can say, Simon Says, flex your arm, and you'll bend it at the elbow. Simon Says, hyperextend your neck, and you'll look up towards the ceiling. And so those are some terms that describe the motion of the joints. Now, to describe the joints themselves, I do want to call attention to this, and then I'll tell you why. I'm not a big believer in memorizing long lists of things for the sake of spitting them back at me on a test. I would rather see you apply knowledge. So we're going to talk about the application of this knowledge. But there are different types of joints. We have, for example, hinge joints. And they only move in one direction. They flex and extend, and that's it. So we have the knee and we have the elbow. Your knuckles kind of count. These are joints, like I said, and if you try to move the elbow into a position that it doesn't normally do or naturally do, you're going to injure that person. That's why I mention it. So you should know how your joints move. You're going to be assisting patients with passive range of motion, and you should know that the knee only really flexes and extends. That's all it does. It doesn't move in a circle. It doesn't adduct or abduct. It doesn't do anything else crazy. So don't try to move a joint in a position that's not normal. We have ball and socket joints, and these have like almost maximum movement. They include the shoulder and the hip. So why is this important? Well, because you want to move this joint, this type of joint, through every possible range of motion you can to keep from getting contractures, which I will cover in just a minute if you give me a little time. But there are other types of joints. You're going to maybe look at gliding joints, and those are the vertebrae. We don't worry about them with passive range of motion. You have condyloid joints. Ooh, sorry. My spell correct is on steroids today. Condyloid joints include the wrists, and they sort of move in angles. You can supinate and pronate those joints. And then we have the saddle joint. And the only one that I know of is in your thumb. But those are different types of joints. And why do I want you to know them? I want you to know them because I want you to understand how those joints move. Because when we assist people with range of motion, we want to make sure that we don't cause contractures and that we don't injure them by trying to move the joint in an unnatural way. Okay, so Mrs. Mulcahy, what's a contracture? I never heard of that. Ooh, let me show you a picture. And here's the best picture I could find of a contracture, and this is a woman in a bed. And obviously she's sort of curled up in that fetal position, and what happened was that all of her flexor muscles, which were stronger than her extensors, sort of pulled on the joint because nothing was moving them through a full range of motion. Now, contractures can happen because of neuromuscular disease, such as cerebral palsy, but very often it happens as a consequence of somebody who is immobile. Either they've had a stroke, or they're very weak and they're in nursing homes and they're bedridden. You can have people who have like wheelchair type contractures where they become wheelchair dependent. The most common place where you'll find contractures is in the feet originally, and that's called foot drop. Let me get you a picture of that. So here's a picture of foot drop, and I'm going to sort of point out where the problem starts. It's this plantar. And this is, might start with a patient who's in bed. Maybe they're in the ICU on a vent, and nobody's doing that range of motion, and maybe they tuck in the sheets really tight, and so this part of the foot gets sort of bent in. Thanks, honey. My son's helping with the pointer. What will happen when this person eventually wants to get up out of bed and walk, if they can ever do that, is that they really can't bear weight on their feet, and so that severely impacts mobility. Okay, honey. And we'll talk a little bit when we start talking about interventions, about ways to prevent foot drop and contractures, because they really do sort of set that person up for a lifetime of disability. Now, the this third component of activity and mobility, we're going to talk about balance and coordination, and this is where your book gets into all the different types of gaits. I really don't need you to know the difference between a steppage gait and a scissors gait and a waddling gait. What I want you to note is when you watch a patient walk, when they're getting up out of bed to the bathroom, is their gait steady or not steady? Do they have the balance and coordination to walk without falling? That's what I really want you to care about. So gait. Steady or not steady? That is the question. Okay, so when you're assessing a patient, you want to know what their falls risk is. So you want to see how they walk. And if they have any disturbance in gait, whether they shuffle or they look like they don't have balance or they don't have coordination, or maybe they walk like their legs are a pair of scissors, that's a gait disturbance, and that increases their risk of falls. So that's what I want you to take away from that. Now, the last component is strength. Muscle strength is important. When people lay in bed for a long time, they lose strength, their muscles atrophy. And also without exercise, those muscles will get weaker. If people don't have muscle strength, be very careful getting them out of bed and getting them to walk. Usually strength is something you would have to rebuild gradually after a period of bed rest. So now that we have a good overall grasp of how activity and mobility work, let's talk about the complications of not having activity and mobility. When patients are on bed rest for a long period of time, let's say that they're in the ICU and they're sedated and they're on a ventilator, they have this sort of unnatural state. And it does affect every system in the body. Obviously, we can start with musculoskeletal. We're going to be right here. Okay, so the first thing that happens is that the bones aren't getting stressed, so they're not going to build more bone. They're going to release the calcium into the blood. Your muscles atrophy and get weaker. They're not being used, so they get smaller and weaker. And then we get joint contractures, which I just showed you and just talked about. So those, unless you do something to counteract those things, those are the consequences of immobility. Now, because we've just released calcium into the blood from the bone bank sort of gave us a little extra calcium, we can have kidney stones. Okay, and we can have inflammation of the kidney because of that, and urinary retention to some extent. But kidney stones are common in patients who are immobile because your bones are releasing calcium and they form little stones, and that's very painful and impacts urinary elimination. Gastrointestinal. Okay, so when we stop moving, our peristalsis slows down and can halt, so we end up with constipation and fecal impaction. And so that's going to be another area that we want to target for this patient who is immobile. We want to do all of those interventions to promote healthy bowel function. Respiratory, this is a big one. People are at risk for complications. Now, if you're laying in bed, your breaths become mostly shallow. You might not be able to cough effectively to mobilize secretions. So you're susceptible to having extra secretions. They become like that petri dish that we talked about, and you're at risk for pneumonia. You're at risk for atelectasis, which is collapse of the alveoli because you're not expanding them enough. And you're at risk for pulmonary embolism, but that's really secondary to this down here, deep vein thrombosis. When blood stays still, it likes to clot. That's what it does. So if you're laying still in the bed and nothing is helping your veins return that blood to your heart, you end up with a blood clot usually in a leg. Now what happens is that clot can dislodge, it travels, it usually ends up here in the pulmonary circulation, in the lungs, so you end up with that pulmonary embolism. Other effects on the cardiovascular system, postural, this should say hypotension. I did not obviously make this picture, I just kind of grabbed it. But this should say postural hypotension, which means that when the patient is laying down, they can maintain a blood pressure, but when they start sitting up or standing up, they get very dizzy and weak, and they can sometimes even faint on you. It's orthostatic hypotension is another name for it. So that happens because you're deconditioned and your cardiac output is reduced, and you're not putting out enough blood to sort of supply everything. And your heart will start to atrophy just like all your other muscles because it's not getting used. Metabolic, well, you end up with glucose intolerance. The skeletal muscles are a big storehouse for glycogen. Glucose is the primary fuel for the muscles. When the muscles aren't getting used, insulin resistance rises. You also end up with a negative nitrogen balance because as your muscles are atrophying, they're releasing their proteins into the blood. That tissue is breaking down and being released into the blood, and you end up excreting it through the urine, so you now have a negative nitrogen balance. Skin is absolutely impacted by immobility. You see people with turning schedules at least every 2 hours, but when you have constant pressure on bony prominences, your sacrum, your elbows, your shoulder blades, the backs of your heels, you're at risk for pressure ulcers and skin breakdown. So those are some really important things. Now, neurological, this really is more psychiatric, but you have people that suffer from depression and anxiety. They get very apathetic, and they feel very sort of demoralized. People need to feel freedom of movement in order to feel normal and good about themselves. So your patients who are in bed for prolonged periods, remember that bed rest is not benign. It is not easy on the body. Sometimes we have to impose it. For example, if you're on a ventilator, you're not going to get up and walk. If you have something, you're in traction or whatever, you might have to have a period of enforced bed rest. However, it shouldn't be something that we do routinely because bed rest is really not necessarily a benign intervention, and the risks many times will outweigh the benefits. And one thing that I want to add to this discussion is that so far we've been talking about patients with severe impairments in physical mobility or who are on enforced bed rest. But some of these complications will occur in a lesser extent to people who have normal ability to move and yet lead a sedentary lifestyle. And so things like cardiac muscle atrophy. If you don't move enough, you're not going to stress those muscles out. Osteoporosis, another condition more likely to happen in folks who have a sedentary lifestyle. Glucose intolerance is associated with diabetes. We know that people who are physically active have lesser risk of having diabetes. And we know that normal movement promotes healthy functioning of all the body systems. And so that is something that we might want to target some clients who are at risk for disease or who have diseases like hypertension or diabetes. We might want to counsel them about the benefits of exercise. So our assessment of the patient who has a suspected unmet mobility need, is really going to rely on history and inspection for the most part. We're going to want to know what their daily activity level is. Are they able to eat? Can they dress themselves, groom themselves, bathe themselves, toilet themselves? The person, remember, with functional incontinence is a person who has bladder control but can't get to the bathroom in time. So if that impacts, if their activity intolerance or their impaired mobility affects their urinary continence, we want to know about that. If it leads to self-care deficits, we want to know about that. We want to know how they ambulate. Do they need assistive devices? And from your lab, you probably remember we have different assistive devices. There are canes, crutches, wheelchairs, different types of braces, different types of devices that people can use to help them ambulate. We want to know, do they need help? with getting in and out of a chair, getting from a bed to a chair, getting into a car, those kind of things we want to know about. We want to know if they need assistance with cooking, cleaning, shopping, all as a result of their mobility. Okay, and then we want to know about activity tolerance when we're asking questions. So what types of activities make you tired? How far can you walk before you get tired? Do you ever experience dizziness, shortness of breath, or other problems when you walk down the block or have other moderate activity? You want to know what that person's exercise patterns are. What type of exercise do they carry out to enhance their physical fitness, if any? We want to know other factors affecting their mobility. Do they have environmental factors? Does their house have stairs that they can't climb? Are there other things that might make the home unsafe and pose hazards to that person? And we'll get further into that with safety. Do we have any chronic health conditions? So under that, you could have, things like muscle disorders, like muscular dystrophy and cerebral palsy, which leads to spasticity of the muscles, heart disease, lung disease. Remember, these lead to activity intolerance, and we talked about that with oxygenation and circulation. Do you have any musculoskeletal disorders like arthritis? Do you have osteoporosis, which might lead to fractures of the vertebrae or things like that? How about chronic back pain? And then we look for things like history of CVA, which is a stroke, which might leave that patient with one-sided weakness. And then, obvious things. If you see that the person's in a wheelchair, do they have spinal cord injury? What was the nature of their injury? Okay, and then financial factors. Do you have what you need to get the assistive devices and to get, help in your home? And when we do our physical exam and we're looking at that person and observing characteristics, things that we want to look at are things like body alignment. Do they have any postural disturbances? Does anything look abnormal? Let me get you a good picture of different curvatures of the spine, normal and abnormal. And I can sort of give you a sense of what might go wrong. You're going to see some of these pictures over and over again. You're going to see them in 137. You'll probably see them again in musculoskeletal. Don't know if they would end up on an exam, but they might. So you might want to pay attention here. So I'm going to start at the end with the good posture. This is what you hope to see, that everything is in line. That line is in perfect alignment and the person's doesn't have any abnormal curvature of the spine. The spine sort of follows that normal S curve. This is just a person with bad posture. You can see the shoulders are slumped and the head is forward, and that kind of throws the body out of alignment there, and it's going to lead to a lot of back, neck, and shoulder pain. Thoracic kyphosis is something that happens with aging as the intervertebral discs tend to shrink in. The person loses height. Sometimes as those discs collapse, you get this exaggerated curvature of the thoracic spine. Lumbar lordosis is common with pregnancy or obesity because as the belly kind of weighs down, that person is forced to curve out their lower back in order to maintain their center of gravity. The sway back is this guy, he kind of has to lean back to maintain a center of gravity. So those are some things that you might observe on inspection when you look for body alignment. You're also going to look at gait. Now, if you ever get into PT or if you work in a neuro unit or something like that, you might get into all the different gaits. Just remember, what I want you to know is steady or not steady. Are they going to fall or not? How much help do they need? That's what the nurse really needs to know. There are other things. When you see certain gaits, they will suggest that that person has had a stroke. Some gaits will suggest that the person has Parkinson's. Some look like cerebral palsy. There's different gait disturbances. But what I want you to notice when you watch a patient walk, are they wobbly or are on their feet and steady, and they're good to go. Because that's really what's going to save you from a lot of paperwork. Okay, you can also look at the pace when a person walks, fast or slow. You want to know sort of the appearance and movement of joints. It's another thing you're looking for. Sorry. So you want to know joints when they get inflamed. I'm going to pause this for a second and find you a picture. But you'll see like swan's neck deformity. The joints get very knobby and red, and the digits get out of alignment. Let me just get you a picture and I'll show you. It's easier. And here it is. That's a picture of a person that has rheumatoid arthritis. And you can see that the joints get deformed. When you palpate over them, you might feel that they are a little bit warmer. And they will look red. The patient will report to you that there's tenderness and pain, and you're going to see a limitation in movement. With every joint that you look at, you're kind of going to look and see, does it have a normal range of motion? Does it look normal? Is there swelling? Is there redness? Does a person complain of tenderness or pain? And then you can palpate over the joints for tenderness, and then there's something called crepitus or crepitation, and that's sort of a grating sound that you get and a feeling of bone rubbing on bone. So you would note that. Next, you want to kind of look and see how much movement they have. You're going to move that joint through a range of motion. Let's just move that over here. We don't need it. So when you move that joint through the range of motion, you're going to feel for any stiffness. If it's a ball and socket joint, it should be able to move in a circle all the way around. And examples of those ball and socket joints, again, are hip and shoulder. If it's a hinge joint, it should fully extend and fully flex. If you can't do that, you're looking at a person who has either contracture or just very tight muscles or even pain. So you're going to look at that. You're going to look at muscle mass and strength, and we will teach you techniques for that in 137. One of the ways you would do this is to assess grip strength in both hands, compare, and there are different scales for measuring those things. You might have the person sort of put their foot on your hand and push against your hand to see how much strength they have. And then you're going to assess their activity tolerance during an activity. Now they can tell you, during the history, they're going to tell you what their activity tolerance is, but there's nothing like seeing it for yourself. If you get that person up to go to the bathroom and they're out of breath by the time you get back to bed, they have a very poor activity tolerance. If they're able to walk up and down the hall, sometimes you'll even do a walking pulse ox with that person. If they're able to walk up and down the hall and they can maintain their pulse ox and they are breathing and they're talking and they look like they're not labored at doing any of it, then their activity tolerance is pretty good. Now, when you're assessing that, if the person all of a sudden gets pale, if they say, oh, I'm dizzy, I'm weak, if their heart rate or respiratory rate goes kind of crazy, if you're checking those things. For example, if you had the person on a walking pulse ox and you were assessing the heart rate and the pulse ox and you were watching their respirations periodically, or if they were on a telemonitor, if you saw changes in those things, you would stop that activity right away. Any complaints of dyspnea, shortness of breath, or chest pain, obviously, right away, stop the activity and get them back to bed and deal with that. But you're going to assess their activity tolerance. When do they start getting tired? How many steps can they take? So those are some ways that you would assess for problems with mobility. And obviously, you're going to walk into a room and see if your patient is in bed and they're contracted and they're not getting out of bed, or if they're ventilated, or any number of things where they're just too sick to be out of bed. Even your fresh post-ops who haven't been ambulated yet. You know that they're at risk for all of the problems associated with immobility and disuse. So now we can come to nursing diagnosis, and there are three big ones that we're going to use, and then there are always ones that are related. But we'll start with activity intolerance. We just talked about ways to assess activity intolerance, and so this becomes a diagnosis that we want to look at. And it's defined as insufficient physiological or psychological energy to endure or complete required or desired daily activities. I don't want you to memorize that, but just kind of understand what it involves. there are different levels of activity and tolerance, and you're going to want to target your patient for intervention based on how severe their problem is. Now, another big diagnosis that we have is impaired physical mobility. Impaired physical mobility might be, say, related to one-sided weakness secondary to CVA, as evidenced by inability to bear weight on right leg, inability to assist with transfer on right side. Those kind of things would be your impaired physical mobility. And these are people who have limitations in purposeful physical movement of the body or of one or more extremities. And there are a lot of specific variations. For some reason, impaired bed mobility seemed to be a real popular nursing diagnosis last year. Everyone wanted to use it. Impaired bed mobility, just so you know what it is a patient who, even within the bed, needs assistance to turn, to be positioned. And so those are people you would definitely want to target for intervention because they're at risk for a lot of complications. Impaired walking would be a person who maybe needs assistive devices to walk, or physical therapy. Impaired wheelchair mobility, somebody who who can't operate their own wheelchair, needs somebody to assist them. And impaired transferability, where they need assistance to transfer from bed to chair, from wheelchair to car, whatever the case is. And then we have risk for disuse syndrome, and that is a risk diagnosis that applies when we're at risk for deterioration of all the body systems as a result of prescribed or unavoidable musculoskeletal inactivity. And that's so when we're talking about the people who are on complete bed rest, your ventilated patients, intubated and they're not moving by themselves, people with chest tubes who have a hard time getting around, and people who maybe have traction, which is not common anymore but was at one point. Anybody who's going to be in that bed for a prolonged period of time is at risk for disuse syndrome, and we would want to target all their body systems with intervention. So those are your nursing diagnoses. So once we've identified what our key areas that we want to target are, we start to make our care plan. We make some goals that are specific, measurable, realistic, time-oriented, and then we implement our interventions. So some appropriate goals for the patient with an unmet physical mobility need would be, these are some samples. Client will have increased tolerance for physical activity, and that would be individualized to that patient's existing tolerance and maybe their baseline. So if today their activity tolerance is that they can walk 15 steps without getting tired, maybe the client will walk 25 steps prior to discharge, and we anticipate discharge in 2 days. That could be a realistic goal. A goal might be to increase ambulation and or participate in ADLs. So a patient will walk down the hall today and shower. That might be your goal for that day. Absence of complications related to immobility, very important goal, and a lot of interventions in your nursing care plan might not relate to your primary diagnosis as much as they relate to keeping this patient free from the complications of immobility, particularly those of you who work in ICU with sedated patients who are on ventilators and who can't move. So a lot of your care plan will be addressing that. You'll be worried about skin breakdown. You'll be worried about making sure that that person can mobilize secretion so they don't get a pneumonia. You'll be watching to see when the last time they had a bowel movement is and making sure that you're promoting good elimination. All of those things that we talked about in the complications of immobility, we're going to work really, really hard to keep them free of those problems. And that might take the form, and we'll talk about specific interventions, but we might have a whole care plan that's based on that for our really vulnerable patients. We also want them to be free from injury, so injury from falling or from improper use of body mechanics. Whatever injury they're at risk for is what we would be looking at. So now we can start talking about interventions, and first we're going to talk a little bit about proper body mechanics. And I'd like to say a word about proper body mechanics. They are important. They are critical in maintaining your safety. However, proper body mechanics alone will not save your back if you're repetitively lifting more than 51 pounds, if you are not using assistive devices that you could be using if you're not asking for assistance with patients who need more assistance than you can give them. Nursing is ranked as the 6th most likely occupation to end in disability because of job-related injuries, and things like belts, the back belts and things like that don't really help. What does help is, using good body mechanics, using assistive devices. The Joint Commission now is really recommending, and the American Nurses Association has seconded this, that assistive devices be available to nurses to help lift and transfer patients, and that, don't ever do anything alone that is outside what your back can handle. And really, 51 pounds is the max that nurses should be lifting if you're the average nurse, and even then only under controlled circumstances where you have ways to reduce the risk to your back. But let's talk a little bit about what proper body mechanics looks like. Number one, you lift with your legs. Those strong, large muscles in your quadriceps are much better equipped to deal with the heavy loads than the tender little muscles that hold your vertebrae in line. Lift with large legs. No, it should be your legs. Sorry. Okay, so lift with your legs. Brace your abdomen when you lift or turn or transfer patients. Sort of tighten those tummy muscles. You might even tuck your pelvis under to protect that lumbar curve in your back. Widen your base of support. And that means to have your feet kind of spread a little bit farther apart, because that's going to lower your center of gravity and make you more stable for lifting. Another thing that you're really going to want to do is avoid twisting. When you have heavy loads, you really don't want to put that strain on your muscles. And you want to avoid stooping. So raise the bed to working height. And I'm capitalizing this, not so much because it's a test item or anything like that, but more because I see a lot of people testing out of skills, both at St. Francis and at the other school that I work at. And what I've found is that people forget to raise the bed to working height. And so I'll say to them, how's your back feel? And all of a sudden they know, that people who know me know that they have to hit that button and make that bed go up. Because if you do that over and over again repetitively, you're going to be bending at the waist and you're going to be putting strain on your lower back. That's why we have beds that have those buttons on them. Raise the bed to working height. If I see you do it when you're testing out in your lab skills, I'll usually tell you, okay, you've got to go to corporate health now because you just slipped a disc. And that's usually a good reminder. And then I let you finish the skill. But, make sure that you have that. And I'm just going to put this down here because I think it bears repeating. Don't try to be the hero and lift and turn these people. Even if you're a bigger guy, you don't have to prove anything. It's safer for them and safer for you if you use the assistive equipment. And Joint Commission and OSHA have really come out strongly, and the American Nurses Association, for safe patient handling. And by safe patient handling, they mean what's safe for you as well as the patient. Now, you're also going to teach these principles to your clients who maybe have back injuries. If you end up working in ambulatory care, you might have a lot of people coming in and out with back injuries, and so one of your interventions is going to be to teach them proper body mechanics. But remember to use them yourself. It's important. Okay, so now we're going to talk about positioning clients. That's a very important part of your job. Positioning a client, making sure that they're in good body alignment, and changing that position regularly, at least every 2 hours, more often if their condition warrants it. Those are essential things that you need to do as a nurse. Most people, if they're in a position too long, they start to get uncomfortable, they'll move around a little, they'll shift this way, that way, and they sort of avoid injury, and they reposition themselves. You might only need to remind them maybe to put a pillow between their knees, or, keep their body in good alignment. However, we are going to encounter clients in the clinical setting who are very weak, who may be frail, who may have dementia issues where they don't remember how to turn or how to move themselves. In the end stages, you will find that. You'll have people who are in pain and they don't want to move because they're afraid that their incision will hurt or that whatever pain they have will be aggravated. You might have people who have spinal cord injuries and paralysis, or you might have people who are unconscious or people who are sedated. If you're an OR nurse and it's a long case, you're going to have people who are positioned in the OR, sometimes in very awkward positions for long periods of time. So you need to be able to address issues that arise. So for every client that's in that position who needs to be turned frequently, we're going to assess the skin on a regular basis and provide really good skin care as well, because their biggest factor when you get to the stage where you can't turn yourself is skin breakdown. Any position held for a long period of time can be detrimental to a client, and that's why repositioning is really important, because when you're laying in any one spot for a long period of time, you're putting pressure on the tissues, on the nerves, on the blood supply, and that's going to interfere with healing. It's going to predispose you to those pressure ulcers. So when we're positioning the clients in bed, some basic principles to remember: you want to make sure that the sheets are dry, that they're wrinkle-free, that the mattress is appropriately firm. You might have special mattresses, and you're also going to provide ways to prevent foot drop. And we kind of talked about that when we looked at assessment, and I think when we did the overview. And, for that, don't tuck your sheets in tight around the feet. What you're going to end up with, the calf muscles are very strong. Speaking of flexors and extensors and what muscles pull what, your calf muscles are very strong, and they will pull on those tendons, and you'll get that shortening of the opposing muscles, and so you'll get that foot drop. And those people, once they regain the ability to walk, have a very hard time walking on feet that just won't go flat against the floor. So don't tuck your sheets in tight around the feet, and you can use a footboard or foot cradle, sneakers, other positioning aids to make sure that client keeps their feet in a natural alignment. You want to keep all body parts in natural alignment, by the way. So even if the patient, even their hands, you might have a hand roll or a trochanter roll, different things that we might use to assess patients. So let's look at some positions. We have supine. And supine is laying flat in the bed. Now, sometimes this is a good position for maybe if you're doing a bed bath or something like that, if the patient can tolerate it. If they need their head of the bed elevated so that they can breathe easier, then that's what you're going to do. But that's your supine position. Oops, sorry. So next, let's look at sideline position. Sideline position can be very comfortable. So after the person's been maybe in supine, or we'll talk about semi-Fowlers in a minute, it's important sometimes to lay them on the side. Now, if you look, the patient's in good alignment. They've got pillows supporting their top knee and their top arm, and they can get very comfortable in this position. Turn them from one side, then turn them to the other as condition permits. Obviously, if they have some kind of issue where they can only lay on one side, then you're looking at supine side and maybe prone, which we'll look at next. And prone is laying on your stomach. Prone position is very good for certain clients, and you can see where those pillows are placed. You might want to elevate the feet a little bit to keep them in a natural alignment, and you might want to pillow sort of under that pelvis just because it's comfortable. And helps that person maintain that face-down position. Now, supine position is very good for people who have had back surgery, and it's actually very good for people who have had amputations. People who have had amputations are at risk for developing what's called flexion contractures, and we'll talk about it musculoskeletal. But this is just a good position for those folks. People who can tolerate it, it can be an alternative to other positions. Now let's look at semi-Fowlers. There we are. And semi-Fowlers is just kind of sitting like supine position with the head of the bed elevated. When you're in semi-Fowlers, you really don't want to put a pillow behind the knees because that's going to prevent venous return. You want to elevate the feet maybe so that the blood returns to the heart, but you don't want to put anything that's going to constrict blood flow. So don't put a tight pillow roll behind the knees, because that's going to sort of prevent venous return. But that's semi-Fowlers, and that's a pretty common one. So if you alternate between semi-Fowlers, side lying, and then maybe if you can tolerate prone, you can do that. Most people really don't like to lay prone. And it's a little hard to get them into that position sometimes. High Fowler's is really that 90-degree angle that we talked about in oxygenation, where they're almost sitting straight up in the bed. That's your High Fowler's position. Of course, we know what orthopnic is. It's when they're leaning over the bed with those pillows on the overbed table to open up the chest, maximize chest expansion. So those are some ways that we position clients. So some of the skills that we're going to talk about now are a review from what you learned in the lab, and that's okay. I'll be really quick. I'm not going to reteach everything because it's a waste of your time. You just review. Or you can bring your muddy points to class and we'll go over them, and that's fine. But assisting with ambulation is one of the major interventions you're going to do. Early ambulation following surgery is probably one of the biggest things you can do to keep patients healthy. It makes me very angry when I see somebody who's been in the hospital for 10 days after a routine surgery, an appendectomy. They could have been home in 2, but nobody got them up and nobody got them walking, and they ended up with a paralytic ileus, or they ended up with a DVT, or they ended up with pneumonia. That's just unnecessary. So good nursing care involves early ambulation. The way that we started, we let them dangle first, let them hang, sitting on the side of the bed, hanging their legs over. Let them get used to the change in blood pressure. I usually also assess their strength before I get them out of bed. I've mentioned that I still work in labor and delivery. And I want to check their leg strength to make sure their epidurals weren't off. With your patients who, you're not sure what their strength is, it's the first time you're getting them out of bed, you want to check those leg muscles and make sure they're going to bear some weight. We want to encourage independence, but assist as needed. So when we get them up out of bed, we're powering off with that strong leg. We walk on the client's weak side. What could their side be weak from? Why is that a consideration? Well, people who have had strokes are usually weaker on the side that's affected, the opposite side from where the brain was injured. So if they had a right-sided brain event, their left side will be weak. That's one reason. Maybe they had knee surgery or hip surgery, and on that side they're a little bit weak, or they've had a fracture, whatever. So walk on the client's weak side, because that's where they're going to need the assistance. If your client begins to fall, don't try to stop them. Just ease them down to the floor, and maybe the next time you get them out of bed, you get 2 people to walk with you, and you have a gait belt with handles. That's always helpful. And use your assistive devices as appropriate. If this person isn't fully weight-bearing, they need something like a walker. A lot of your knee patients or hip patients are going to go home with walkers, and they should be trained on how to use them. Some people might need a cane. Your stroke patients who can bear some weight on the weak side can walk with a cane. Crutches, that's another intervention. A lot of times crutches are temporary because they're not the most comfortable assistive device. But you learned all of the different gaits. Definitely review them at some point, 4-point, 2-point, 3-point, swing through, all that stuff. Just take a look at those and be familiar with them. But that's one intervention that we look at, assisting with ambulation. And like I said, that can be one of the things that gets your patient well a lot faster than you think about it. It's one of the things that nurses never get medals for, but it can really make a difference in the outcome. Next, we're going to talk about range of motion exercises. And I know I showed you some pictures of contractures, and I told you how serious they are. So I hope I've reinforced the idea that range of motion exercises are important for your clients. There are 2 basic types of exercises you do. There's active, where the patient does all the moving. And you go from head to toe with this. You're going to go, maybe have them rotate their head side to side, hyperextend the neck, flex the chin to the chest, and circumduct that head in a circular movement to move the head through the full range of motion. And you go down. Shoulders, again, they are your ball and socket joints. So you want to move them all the way around in the front, around in the back. You want to abduct them, adduct them. We'll play Simon Says and get that down pat. But that's your active range of motion. You would go even down to the knuckles and the toes, getting them to move each and every joint in a full range of motion. And once they understand how to do it, you can just give them reminders. And then we move on to passive range of motion. And passive range of motion means that someone assists. Now that can be PT or it can be the nurse with range of motion. You're going to be the person who moves their arms up and down and flexes and extends and rotates and does all of that for them. The goal with passive range of motion exercises, if the person has some kind of impaired mobility, is eventually to progress to assisted range of motion and then finally to fully active range of motion. You don't really want to let that person be passive range of motion forever unless they really can never do it again. You want to try and restore as much function as you can. Passive range of motion is very important for your weak patients, your sedated patients, people who just maybe have cognitive issues, people who have a stroke. So you want to move the muscle through its, or the joint through its range of motion. You want to clothe them in a loose gown, cover them with a bath blanket, ensure privacy. Use correct body mechanics, raise the head of the bed to working height, or raise the whole bed to working height. Only expose the limb that's being exercised so that they're not, hospital gowns are not very modest. So when you're doing range of motion exercises on somebody's, say, leg, you want to make sure that they're covered on all their other extremities. Just one at a time should be exposed. You want to support the joint above and below with your arms, so it's not just unsupported. And that way you have greater control over that movement. And you want to use a firm, comfortable grip, but at the same time you have to be fairly gentle. Move the body parts smoothly and slowly. Don't be jerky, don't pull on them, don't let the muscle kind of flop over. If you do that, you can end up with a muscle spasm or rigidity, and you're sort of defeating your own purpose there. Never move a joint past its normal range of motion. You're gently stretching, but you don't want to pry muscles apart. You have that person who is contracted. You're going to kind of go to the point of resistance. And then, if you get a spasm, stop the movement temporarily, but when the muscle relaxes, you're going to stretch it again, gently and slowly. Slow, firm pressure if they have contractures to the point where you meet resistance. If you have joints that are inflamed, or if you have a surgical incision, proceed with caution. And you're going to teach the client's primary caregiver. If they're going home with a family member, make sure that that person knows how to do the passive range of motion. While you're doing this, it's a really good time to assess their skin. You can do it pretty much while you're doing the bath. You wash the arm, and you do range of motion on the shoulder and elbow. And at the same time, you can assess their skin. So that's your range of motion. And it's, when you hear it on a video or you read about it in a book, it's not going to come to life. So when we get to class, I'll show you a movie, and then we can practice. And we'll do those Simon Says things, adduct your shoulder, and then we'll do it with partners so that you get an idea of what range of motion should look like. Okay, so let's talk about preventing the complications of prolonged immobility. And one of the biggest ones you're going to work on is preventing skin breakdown. When you get to integument, you're going to think about it a little bit more. But this is such an important thing, really. Once you get a bed sore, they are really, really difficult to treat. They tend to get worse instead of better, particularly if they're on the sacrum and exposed to wetness from incontinence. So some of our interventions are going to be positioned every 2 hours at the minimum. You can position more frequently. When you're doing your hourly rounds, you might want to see if that patient needs to be repositioned. You're going to perform frequent skin assessments. So every time you're doing a bed bath, or if the tech is doing a bed bath, they're going to let you know if they see anything. But really, you have to assess that patient's skin at least once a shift. You might want to use special mattresses, special beds that kind of rotate the pressure so that pressure doesn't build up under any one area. You definitely want to keep linens dry, keep them wrinkle-free. So if that patient is frequently incontinent, you're going to have to be in there a lot, checking them to make sure that the pad underneath them. It's one of the reasons hourly rounding has been such an important initiative. You don't want to leave anybody sitting in wetness or in stool. You want to make sure it's wrinkle-free. And you're going to support all those bony prominences with pillows. Now, in St. Francis, they use something called Mepilex, which is like a great big square Band-Aid you can put on the patient's sacrum. They can be heart-shaped too. I've seen that. So if you have that product, you apply it to the sacrum, and that kind of keeps the skin, dry because it's got a waterproof surface, and it pads it a little bit. So hopefully You're changing that every day, or if it gets soiled, you're changing it more often. There may be other products you're going to use. There might be skin barrier creams. There might be skin protectant creams that kind of protect those bony prominences. But preventing skin breakdown is going to be one of the biggest things that you do for the patient with immobility. We want to prevent respiratory complications, and frequently, particularly with your surgical patients who aren't fully ambulatory, you're going to try and teach them to use that incentive spirometer to mobilize. Again, when we lay in bed for long periods of time, we don't take those deep breaths. So we need to open up those airways. We need to encourage coughing and deep breathing to open up all the airways and to mobilize secretions. We're going to position that patient to mobilize secretions as much as they can tolerate. Turning them from side to back also helps. Ensuring adequate hydration is important. That's also important for skin care and for preventing constipation, which we'll talk about next. And again, some of this is review from other chapters, but because immobility affects every system in the body, we'll talk about preventing constipation and fecal impaction. You want to make sure the patient's adequately hydrated. If they have a diet order that allows them to take in fiber, if they're not just clear liquids or something like that, or NPO, we're going to try and encourage some fiber intake. Some of these folks will be on tube feeds if they're really have prolonged immobility. And so that's usually not a problem. But we're going to administer medications to promote bowel function as ordered and appropriate. And we're going to monitor. Make sure that you know when the patient's last bowel movement was. Assess for any signs, symptoms of constipation or fecal impaction. Are they distended? Are they tender? Have they passed gas? Make sure they have bowel sounds. And just, be aware that that person is at risk for those things. So next, let's talk about preventing deep vein thrombosis. It is a very serious complication of prolonged bed rest. In some cases, like for knee surgery or other elective things, it's considered a never event. Immobility is one of the risk factors because it promotes venous stasis. It makes the blood want to stay where it is, and blood that stays where it is wants to clot. That's just how it works. So some of the things that we're going to do is we're going to promote venous return, elevate the legs, avoid crossing the legs. Don't put pressure on the vessels, so no pillows behind the knee, and don't massage the calves. If you're going to put a pillow under a patient's feet to elevate the legs, make sure that the vessels in that popliteal space are not compressed. You really want to encourage venous return. You can use compression devices such as TEDs, which are those compressive stockings, the white stockings, or we'll see these in the hospital a lot, sequential compression devices, also known as SCDs. They look like Velcro leggings that attach to a pump, and they blow, they have air that kind of circulates and pushes the blood back towards the heart. And they're found to be very reliable in preventing deep vein thrombosis. You might have orders for anticoagulant therapy for patients on bed rest. Lovenox, heparin, not uncommon to see that, and in fact that is a best practice. And we can assist this patient with some exercises, calf pumping, quad setting exercises, range of motion, to promote venous return from the lower extremities back to the circulation, central circulation. If we think we see a deep vein thrombosis, what it looks like, I'm sure I talked about this in circulation, is that warmth, redness, swelling on one side, and the patient complains of a lot of tenderness and pain, particularly with walking. I just want to stress that if you see that, don't let the patient out of bed. At that point, you don't want to do anything to dislodge a clot, so no massaging of the calf. You're going to have bed rest until you can get a doc in there to write some orders and evaluate that patient. They're probably going to go down for Doppler studies to rule out your DVT. And if they are found to have one, they'll go on heparin. This is sort of outside the scope of immobility. It's just because that it's such a serious thing that can happen, and immobility is one of the primary contributory factors. I'm re-stressing it because it's something you'll see over and over again. And remember that kidney stones are one of the complications of prolonged immobility. What we're going to do about that is maintain adequate hydration and be aware of the signs and symptoms of kidney stones. The patient will complain of severe flank pain, back pain. We want to be alert to that because it is a possible complication. Now, one last word about interventions along the lines of activity and mobility. There are many diseases that have a lifestyle component that are related to sedentary lifestyle. Okay, and so for those folks, you might want to help them plan an exercise program. Usually, you're going to start them out walking if they've been sedentary for a long time, and maybe doing some resistance training and flexibility training. But I didn't really want to bog you down in that. What I want to drive home to you, since most of you are going to learn acute care first, and that's where you're going to work your first year of nursing, and because NCLEX really stresses the acute care, I wanted to sort of really concentrate on the hazards of immobility. So we're finished with activity and mobility. Our next topic will be pain and comfort. So see you soon.